Hey everybody, welcome to another cardiopulmonary lecture. This one is a bit long, so apologies in advance. We're covering a lot of stuff. We may break it up into two. We'll see how it goes. This is Chapter 3, Ischemic Cardiovascular Conditions. So this whole chapter is going to be about conditions that seem like different disorders. They don't necessarily seem related to a layperson, someone who's not trained like us. But we're going to learn, if you don't already know, that they all share a common pathophysiology of arteries. We're going to be talking about diseases of arteries that all have some related causes and risk factors. So to do that, first we need to talk about arteries. Specifically, we're going to be talking about coronary artery anatomy. So the technical names for these three layers are the tunica adventitia, tunica media, and tunica intima. You'll also see these just called simply the outer, middle, and inner layer. The outer layer is fibrous, has a lot of collagen. It is there for protection and to sort of provide tensile strength to the vessel. The middle layer is composed of smooth muscle. This is where vasoconstriction takes place. The sympathetic nervous system has a lot of innervation of this tunica media throughout our body and can dilate or can constrict blood vessels to increase blood pressure. And then the inner layer, if you look, it's just a single layer of cells. These are squamous cells. It's called a simple squamous epithelium. And this particular simple squamous epithelium is called the endothelium. It lines the entire cardiovascular system. It's inside the heart, the coronary arteries, which is what this picture is, and every blood vessel of the body, including veins, capillaries, lymph vessels. So it's all over the place. And it's this layer in particular that has been identified as the location of most, I should say much, I don't know if it's most, but probably is most cardiovascular pathology. One thing that is interesting about this layer and kind of foreshadows some of the problems with this layer is that it is selectively permeable to a lot of different things. Two of the most common are LDL, which we'll talk about soon. It's what we call bad cholesterol, low-density lipoprotein, and fibrinogen. Both of these play a role in the diseases we'll be talking about later. First, let's talk about myocardial perfusion. After all, that is the job of the coronary arteries. Their job is to provide blood to the myocardium. That's, if you remember from our first lecture, that's the muscle within the heart. Not the epicardium or endocardium, but the myocardium. And perfusion is based on diastolic blood pressure. Interestingly, not systolic. The nature of the circulation in the heart is that under full systole, these vessels are closed. So diastolic blood pressure is what fuels perfusion. Vasomotor tone plays a role, resistance, and left ventricular end diastolic pressure. The coronary vessels deliver the blood and are responsible for myocardial perfusion in a healthy heart. Now, we're going to talk about a disorder that can mess that up. It can mess up the ability of the coronary vessels to deliver blood to the myocardium, to inhibit myocardial perfusion. That disorder is called atherosclerosis. You've probably heard of this. It's a hardening and a narrowing of arteries. It could be coronary arteries. That's what we're talking about primarily right now, but it could also be cerebral and would increase the risk of stroke, or it could be peripheral and increase the risk of peripheral vascular disease. there is a plaque formation of lipid and thrombus, fibrin and fibrinogen in particular, and fat, particularly something called foam cells, which we'll talk about later. And there are two phases, atherosis and sclerosis. Atherosis is the development of a fatty streak. If somehow we had a crystal ball and we could see the future, and we could find 10 people that we know are going to have some pretty bad cardiovascular disease later in life, some atherosclerosis, maybe myocardial ischemia, 10 years from now. If we were able to look at their arteries, we would probably already see some fatty streaks forming. And 10 years from now, that would probably be the location of their disorder. And so it is quite literally a streak of fat. And it's formed by these lipid-laden monocytes. So if you look at this picture here, we see some monocytes accumulating underneath the endothelium. That's relevant. Those cells are called foam cells. They are taking in cholesterol and triglyceride and fats and lipids. This cluster continues to grow, and eventually you could imagine that it would cause endothelial separation. When that happens, well, it's not good. That's when sclerosis begins. And the hypothesis is that this is the body's response to injury. The endothelium has ruptured. Collagen is exposed, and our body is hardwired biologically to respond to exposed collagen in circulation because the body thinks there was an injury. We got a wound. We were bitten by a tiger, or something. There's injury to arterial walls, and that injury needs to be repaired. So what happens is blood clots form, platelets aggregate. Fibrin and fibrinogen come out of solution. Red blood cells clot. They get stuck in the fibrin mesh. This is all bad stuff, all resulting in a further narrowing of the artery, maybe a full occlusion in the case of myocardial ischemia. But I'm getting ahead of myself. That's atherosclerosis. So now let's talk about some risk factors. We basically just outlined the underlying pathology behind all of the diseases we're going to talk about tonight. But let's talk about what things place us at risk for atherosclerosis and other cardiovascular disease. Number one, in my opinion, the text doesn't rank them. This is actually an area of research of mine, which reminds me, I do want to point out some research ideas for you guys. Basically, for this class, you'll see under the assignments in the last module that I'm going to give you a few different options for a final project. So you'll have assignments, quizzes, and a final project. No final, no midterm. So I'll try to point out some potential research projects for you guys. There are other options. There are essentially, a book report option, a case. I'll save that for another video that I'll record to explain that assignment to you. But I'll point out some interesting ideas tonight. So anyway, cigarette smoking is a huge risk factor. I'm working on a study now looking at risk factors. I'm also considering maybe writing a book about what we know about cardiovascular risk factors and how much we don't know. One thing we do know is that smoking is absolutely correlated with heart disease. If you look at the graph of heart disease incidence, mortality as well, if you look at heart disease mortality, it's pretty much, you could overlay it on top of the cigarette smoking curve over the last 100 years. Heart disease death is decreasing, and that decrease almost exactly mirrors the decrease in cigarette smoking. It's not causative, but it's definitely an interesting, just an interesting finding. Right now, we think about 15% of all heart disease deaths are due to smoking. One thing that smoking does is it decreases your HDL, your high-density lipoprotein. We haven't talked about that yet, but that's not a good thing for heart disease risk. It also increases fibrinogen, which promotes clotting. especially when there is endothelial rupture due to atherosis. Increases catecholamines. These are your stress hormones. Stress is also a risk factor, and it's not good. So this is a negative for heart disease risk. It makes you more likely to have heart disease. And increased blood pressure, which we'll learn hypertension is highly correlated with heart disease pathology. Physical activity is a big one. Physical inactivity, they believe, is fairly comparable to smoking. So it is a huge risk factor. It influences your lipid profile just like cigarette smoking. Increased physical activity causes decreased platelet aggregation. Another way of saying that would be physical inactivity causes excess aggregation just like smoking. Extra physical activity causes increased fibrinolysis, which prevents clot formation and platelet aggregation, and fibrin mesh formation, which leads to clotting. And it increased activity increases red blood cell compliance, meaning they're more flexible and it's easier for them to move through occlusions. So physical activity is another huge one. Body weight. A BMI greater than 30 is associated with the development of CHD, coronary heart disease. That said, in a study that I'm putting together, which it's an old data set, so take it with a grain of salt, but BMI was actually not associated with mortality, not necessarily heart disease, but since heart disease is one of the biggest causes of death in my sample, that's interesting. But officially, for the purposes of this class, BMI over 30 is associated with increased coronary heart disease risk. This is especially true. Now, this is absolutely true. This association becomes more significant when the body fat is visceral. And this is my phrase here at the bottom, not your books, but waist to hip ratio may be even more predictive than BMI because it tells us how much of your fat you're carrying in your visceral area. Diet is hugely important. This is a broad term. There are all sorts of correlation studies pertaining to diet. You could find a correlation study for each food item in this picture, I guarantee you. So we're not going to go into that level of detail, but one thing that is for sure is that diet influences a lot of the other risk factors. It influences cholesterol, it influences stress, it influences a bunch of other things. So generally speaking, the American Heart Association recommends about 4.5 cups of fruits and vegetables per day, 2 servings of fish per week, and 3 servings of whole grains per day. This has become highly controversial. Diet in general has become controversial here in America. We won't get into that here, but maybe we'll have the opportunity to talk about it later. Blood pressure is a highly predictive coronary artery disease risk factor. It's an independent risk factor, which means independent of anything else is predictive, whereas diet, for example, tends to influence other risk factors, which are independent predictors. This is an independent predictor. Systolic greater than 139, diastolic, or another way of saying that is systolic greater than or equal to 140, diastolic greater than or equal to 90 is considered hypertension, and that is an independent risk factor. Cholesterol. Cholesterol emerged as a pretty big villain in heart disease. There was a study done by Ansel Keys in the 50s that sort of indicted it as a risk factor, and then a much better study, the Framingham Heart Study, showed that it was a heart disease risk factor. That said, the role of total cholesterol is a little bit more unclear. For every study that says it's a risk factor, you'll find another study that says it isn't. However, the Framingham Heart Study is a well-designed, huge study, and they suggest that total cholesterol is a risk factor. So for the purposes of quizzes, yes, it is. Between you and I don't know. What definitely is a risk factor is HDL level. specifically the ratio of HDL to LDL or HDL to total cholesterol, which is this fourth bullet point. There's this idea, well, let's take a second to talk about this. So you have two types of cholesterol, and even that's a misnomer. Cholesterol is a very simple compound that cannot move easily throughout the blood without a carrier. So there are two molecules. One's called LDL, low-density lipoprotein, and one is called HDL, high-density lipoprotein. We tend to refer to these as cholesterol, but they're really a more complex compound that carries cholesterol. You can think of it as a cholesterol taxi or a cholesterol Uber. LDL is really good at delivering cholesterol to the tissues. HDL likes to pick up cholesterol and bring it back to the liver for metabolism and excretion. So based on that information, you would guess that HDL is good, and you'd be right, because HDL pulls cholesterol out of the arteries and other tissues and gets rid of it. LDL brings it to the arteries and deposits it. So the more HDL you have, that's protective within reason. The more LDL you have, that is hazardous. Now, the question becomes does dietary cholesterol influence that ratio? And that is also unclear. We used to assume that was the case, but now we think it might be more related to saturated fat intake than cholesterol intake. What that means is eating cholesterol doesn't necessarily make your cholesterol go up. Your liver is able to make cholesterol, and you have a reflex when you eat cholesterol, your liver stops making it to compensate. So it's really probably saturated fat, although some people even disagree with that and think that it's sugar. It's probably a combination of all of these things. But for the purposes of quizzes, according to the Framingham Heart Study, the cholesterol to HDL ratio is the best predictor of heart disease risk, and it's most influenced by saturated fat intake. Now, personally, I think this is the big one, fasting blood glucose levels, or just refined sugar intake in general, even if you aren't diabetic. But for the purposes of our quiz, a fasting blood glucose greater than 100 milligrams per deciliter is associated with an increased 10-year cardiovascular disease risk. Now, you might be wondering why, because we don't really talk about sugar when we talk about atherosclerosis. We talk about fat and cholesterol and clotting. Well, sugar is known to bind to a few different compounds. It's called glycosylation. One of those compounds is fibrinogen. Another is collagen. Another is antithrombin 3, which is a thrombolytic. It prevents clot formation. HDL and LDL. And isn't it interesting that all of these things are involved with coronary artery disease? So it turns out that sugar makes these things work against us. It makes fibrinogen better at clot formation. It makes collagen more brittle and more likely to rupture. It makes antithrombin less effective. It decreases HDL. It increases LDL's function. So sugar can bind to these things and harm us, and it's a risk factor. So fasting blood glucose is definitely a strong risk factor. There are other risk factors. Family history is huge. Genetics cannot be overestimated. The role of genetics is huge. It's not determinate. It's not like if you have a specific gene, you're going to get heart disease. It just might make you more susceptible to certain risk factors. You know, one person might have the exact same risk factors. I spelled factors wrong, sorry. As another person, but only one of them gets heart disease or coronary artery disease, and that's due to genes. Age, obviously, the older you are, your risk of heart disease goes up. Gender is an influence, absolutely, and stress. Stress is huge. Emerging is maybe one of the biggest. That's kind of a big claim. I mean, there are certainly a lot of evidence to back that up, but as of now, it's not necessarily considered one of the independent risk factors, but it is certainly contributes to heart disease risk. Now we have some emerging risk factors. Various different compounds here involved with clotting and inflammation and fat ratios. I'll just give you an example. CRP, it's an inflammatory marker. Multiple studies show that it is highly predictive of heart disease mortality. So more and more risk factors are coming out all the time. And my research is actually in identifying markers that we can use to predict mortality, including heart disease mortality. So CRP is a big one. So now we're going to kind of shift gears and talk about the clinical course of some of these things. Okay, now we're going to kind of shift gears and talk about the clinical course of atherosclerosis and its ultimate result, which is some type of ischemia. And so that we'll just call that coronary heart disease, and it typically presents in one of four ways listed here. We'll go through these one at a time. Actually, I'm sorry. Let me back up a little bit. So, really quick, because I don't have a slide for sudden cardiac death, let me just talk about it here. So, in about half of patients with coronary heart disease, sudden cardiac death, which is death within an hour of symptom onset, is the initial presenting syndrome. So that's bad news. It's actually quite alarming to me. Now, as I get older, I start getting more and more worried about this sort of thing. I actually witnessed someone who experienced a sudden cardiac death at a birthday party. I didn't know him, but he was a guest of the person whose birthday it was, and it was pretty shocking just how quickly that can happen. The other half of people experience one of these other clinical courses. So we'll start with angina pectoris, or we'll just start with angina broadly, and then we'll talk about stable versus unstable. So angina pectoris basically just means chest pain. It's incredibly common. A lot of people have this. It is a sign that you're heading in a dangerous direction, but it's not necessarily an emergent condition. It's a squeezing, tightness, or crushing sensation in the chest. The referral pattern is pretty broad. That's something you learned or will learn in medical screening. And, it could potentially cause shoulder pain, for example. But generally speaking, it's mid-chest pain. And it's often the reason for seeking medical attention for atherosclerosis or coronary heart disease. It is caused by decreased myocardial perfusion. In other words, an inadequate oxygen delivery. This is painful. Inadequate myocardial perfusion is painful. And it's a balancing act. And what I mean by that, we'll talk about balancing act here with chronic stable angina, is that as long as oxygen demand does not exceed supply, it isn't painful. But the moment that we need more oxygen than we're receiving in our myocardium, it becomes very painful. So you can have two different types. You can have a stable angina, which means it's very predictable. You have a well-established level of onset. I'll give you an example. Where I live, I can walk to our grocery store. It's maybe like a half mile. And so every once in a while, I'll go with my daughter. And I could imagine if I was 10 years older or in worse shape or whatever, the way to the grocery store, because it's downhill, would probably not trigger any chest pain. It's almost no increased cardiovascular demand. But the way up is incredibly difficult. And so you might imagine that I might exceed that capacity where myocardial perfusion is not adequate for the demand I'm placing on my heart. And that would become very painful. People with angina, stable angina, typically will know which activities will bring it about and which won't. And they're able to predict reliably which activities will provoke pain. Now, typically, they'll be receiving medical attention, and they can alleviate these symptoms by either decreasing their exertion level, stopping, taking a break, slowing their pace, or taking nitroglycerin, which causes vasodilation and increases delivery of blood. Now, the last segment is acute coronary syndrome, and there's a few different disorders that fall under this category. It's the same disease. It's myocardial ischemia brought about by atherosclerosis, but it just presents differently. It's a different clinical course for coronary heart disease. The first is unstable angina, and then we have STEMI and non-STEMI myocardial infarctions. So unstable angina first. So it's chest pain without the predictable exertion triggers. So it's inadequate myocardial perfusion, just like stable angina, but it's in the absence of the demands that would normally provoke angina. There's a good chance, if you're working in a cardiopulmonary rehab, that you will be the person to detect this, because you might be working with someone who already has stable angina, and then all of a sudden it becomes unstable, meaning they're having pain at a lower level than usual, or maybe they're just at rest. So what are the causes? They likely had stable angina, and then maybe there was a plaque rupture, meaning the stable plaque ruptured, exposed collagen, causes additional coagulation, there's an injury, and then the artery narrows even further, and it was unpredictable, out of nowhere, had nothing to do with exertion. You could also have a dynamic obstruction, which is basically just a spasm of the artery. So nothing has happened to the plaque necessarily, but something has triggered a spasm, which causes an occlusion of the artery. Inflammation, some type of other irritant has caused inflammation and from an infection, or who knows, or anemia or tachycardia, some other thing that's causing what used to be an adequate amount of blood to not be anymore, like decreased oxygen carrying capacity in the case of anemia, or decreased cardiac output in the case of tachycardia. Or, I'm sorry, with tachycardia, it'd be increased oxygen demand due to increased heart rate. There are some clues that you should look out for as a PT. You should be looking for angina at rest, greater than 20 minutes. I would say any angina at rest is cause for concern, but certainly give it some time. It could just be that they haven't recovered from whatever exertion they were participating in. But greater than 20 minutes, definitely a red flag. Really, angina at a lower than usual activity level period is a red flag. So, be on the lookout for that. If you see it, have the patient rest. If they don't recover, that's a serious concern. Now, there might be other concerns you see that cause you to consider this an emergent condition well before 20 minutes of angina. But, if the patient appears okay other than this chest pain at rest, then you may need to give it 20 minutes. Or just any deterioration of a previously stable pattern. They used to be able to walk every day. Now they can only walk 2 days a week due to chest pain. That'd be a milder form of unstable angina, but it's certainly a clue that something's going on. There's another type of angina called Prinzmetal, which is a spasm, just like we mentioned a few slides ago about a dynamic occlusion. But there are some differences. Both conditions are likely to occur in the hours after waking. This is just due to the chemistry of our blood, high cortisol levels, high inflammatory markers. There's an increased risk in the morning. Unstable angina is much more painful than Prinzmetal, and with unstable angina, it doesn't really go away. Even later in the day, you could still be having pain, whereas Prinzmetal typically eases throughout the day. That brings us to myocardial infarction. STEMI and non-STEMI. This stands for ST segment. There's not a second S there, but ST segment elevation, myocardial infarction, and non-ST segment myocardial infarction, elevation, myocardial infarction. We haven't talked about ECG yet, but this is just referring to a specific part of your ECG called the ST segment. It can be elevated or non-elevated. These are two types of myocardial ischemia. The question is, what's the difference between ischemia and infarction? Ischemia is less oxygen being delivered than we need. And there's, varying degrees of that. It could be minor, major. Infarction is the heart muscle's reaction to that lack of oxygen. It could go all the way up to necrosis with severe ischemia. So infarction is the damage occurring in the tissue. Ischemia is the cause. The type is determined by an ECG. ST segment elevation equals a STEMI. If there isn't any, it's a non-STEMI. A STEMI is worse. Although, there's been some revisions here, but generally speaking, a STEMI is what's called a transmural infarction, meaning this purple in this photo. It's going all the way through from the outer, from the epicardium all the way to the endocardium, whereas a non-STEMI is typically subendochondrial. Now, this STEMI is going to occur distal to a significant occlusion secondary to a thrombus. A non-STEMI could occur for a variety of ischemic reasons, but typically the STEMI is worst due to an actual occlusion or pretty full occlusion at least. Now, both of these are emergent conditions that require medical management. Prompt reperfusion is paramount. So the number one concern is reperfusing the infarcted area, the area that's experiencing ischemia. If there is a full occlusion for greater than 20 minutes, that's irreversible damage to that tissue. There's nothing that can be done. However, if within 20 minutes you're able to do one of the following or all of them, percutaneous coronary intervention, PCI, percutaneous coronary intervention, which is what this picture is. They're placing a stent. They're putting a catheter through with a balloon, they're inflating it, and they're leaving a mesh behind that keeps that area open. Thrombolytics to break down the thrombus, aspirin, anticoagulants, nitrates, morphine, beta blockers, oxygen. Say a little blood is getting through, then we want it to be highly oxygenated blood, right? So oxygen, arrhythmia treatments, heart block treatments, like a pacemaker. So one or all of these things are going to be needed depending on the specific needs of that patient. If we can get there in less than 20 minutes, which you could be a part of in a cardiopulmonary rehab, you could identify an emergent condition and get them to the ER. Less than 20 minutes, we could be okay. Greater than 20 minutes, there's going to be permanent damage. Doesn't mean death. It just, that piece of the heart muscle is not going to function anymore. And depending on where it is, how large the area is, it's going to have different repercussions. That brings us to hypertension. Hypertension is a major risk factor, as we indicated earlier. It has both genetic and environmental causes. Environmental meaning sodium intake, activity level, diet, etc. Now, this is a fairly new blood pressure categorization system. It's a little bit different than mine. When I took boards, there were questions on boards that I needed to have a picture perfect memory of this table for. So just a heads up about boards. And I mean, you'll see that in any study guide you read. So I don't think I'm giving away any secret information there, but an elevated diastolic blood pressure. Now, this is interesting because it's diastolic specifically. An elevated diastolic blood pressure is associated with roughly 32 to 36% increased 20-year mortality rate. So we'll talk about why that is. Why is just your blood pressure being a little higher so bad? I mean, we increase our blood pressure dramatically during exercise. It doesn't kill us. It makes us healthy, right? So what's going on here? Well, it's that constant increased afterload. So if you remember to our first lecture, it's the diastolic blood pressure that determines how much force our heart needs to produce, our left ventricle needs to produce to open the aortic valve. So the higher the diastolic blood pressure, the higher the force is that valve, or that the left ventricle needs to create to open that valve. So that leads to left ventricular hypertrophy, which is not a good thing because that leads to an impaired ability to relax. And an impaired ability to relax leads to diastolic dysfunction. An inability to fully relax means it's an inability to fully fill with blood, which means decreased cardiac output, et cetera, which leads to an increased oxygen demand because now the heart has to work even harder. And if you think back to myocardial ischemia, remember it's a balancing act. How much oxygen is being delivered compared to the demand. So hypertension causes oxygen demand to go up. So it tilts that little teeter-totter, if you guys know what that is, in the wrong direction. It pushes us towards myocardial ischemia. How do we treat hypertension? Well, mild hypertension, pre-hypertension, can typically be addressed with lifestyle modification. Weight loss, decreased alcohol, decreased salt, and increased exercise are fantastic. This is all great for any level, well, most levels of hypertension, not severe. Exercise can be contraindicated or at least require clearance in severe hypertension. But generally speaking, all of these will help any category of hypertension. But once we get past pre-hypertension, we need to introduce some pharmacological interventions because we know at least increased risk of myocardial ischemia. So that could be diuretics to decrease fluid volume and decrease blood pressure, beta blockers, alpha blockers, vasodilators, calcium channel blockers, angiotensin II blockers, and ACE inhibitors, which is angiotensin converting enzyme. These are all different methods for lowering blood pressure. You will find that all of your patients when you graduate will be on these. almost all of them. There doesn't really seem to be much downside to keeping someone's blood pressure where it should be. This would be best, lifestyle modification, but in the absence of that, this seems to be the way to go. Problems do arise when people get prescribed more than one of these, specifically when it's from multiple doctors. So they might be taking 2 diuretics and the other physician doesn't know. As a PT, you're going to catch a lot of those mistakes and you're going to help a lot of people. I can't tell you how many people I've seen who can't stand up because their blood pressure is so low. And then you review their medications and you realize they have 2 cardiologists and a general practitioner and they've all prescribed them the same thing. They all have given them Lasix and they can't even stand up. So you'll be in a position to help those people. Hypertension and exercise. Generally speaking, exercise capacity is reduced by 15 to 30%, even if they don't really have, hypertensive symptoms or other myocardial ischemia symptoms. Just assume there's going to be a decreased capacity. Now, you have to look at more than just what their blood pressure is to determine if they have hypertension, because they may have had severe hypertension that's controlled by medication. So you check their blood pressure, they're in the normal range, but they still have a diagnosis of hypertension. So you need to be aware of that because a lot of pharmacologics won't work as effectively with exercise, especially if you're doing an exercise that involves isometric contraction, meaning a Valsalva maneuver. Any bearing down or isometric contractions will really elevate hypertension. So just be mindful of that. If someone has hypertension, it's not a terrible idea to be checking their blood pressure regularly during visits. In this case, they're doing a stress test, so they have it on at all times. But even in like your home health visit and that sort of thing, you should be checking blood pressure often. Just some examples: diuretics can cause hypo and hyperkalemia depending on the type of diuretic, and beta blockers can also cause hyperkalemia. This all leads to arrhythmias and other issues. So the combination of hypertension and arrhythmias can be problematic. So just be aware, check blood pressure often. I think I kind of got ahead of myself. What are the implications for the PT? Well, this is shocking right here. 1 in 3 Americans have this disorder. So we know how detrimental it is and how much of a risk factor it is. 1 in 3 Americans have it. But here's what's most important to you. 1 in 4 of those Americans have no idea that they have it. So you could be working with someone who's undiagnosed. They don't know they have it. You're not checking blood pressure. That's the problem. You should be checking blood pressure. It's very easy to do, even in an ortho clinic. I encourage you guys, it's tough when you're just starting out and you're telling a ortho clinic owner that you should be checking blood pressure. I get it. But it's a pretty quick step that can potentially save a life, or at least prevent a problematic experience for a patient. And it only makes you look good. I think it makes you look more professional. So obviously in home health or skilled nursing or the hospital, of course you're checking it. But even in places where you don't have to check, sorry, I have the hiccups. Even in settings where you don't have to check it, I would recommend you check it. If you have a patient with any one of these disorders, stroke, diabetes mellitus, coronary artery disease, aneurysm, peripheral artery disease, obesity, renal failure, alcohol, blah, 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 blah. If they have any of these, they are likely one of these 1 in 3s. So even if they don't have a diagnosis, you should be checking their hypertension. These are all predisposing factors to hypertension. Just a quick tip. I don't know how comfortable you guys are with checking blood pressure. We'll be doing it in lab, but cuff size is key. The wrong cuff size, if it's too small, the blood pressure will be way higher than expected, or than the truth. If it's too big, it'll be lower. So anyway, the point is you want to make sure it fits. There's some Velcro on there, and if you're having to really force it to just barely overlap a little bit of Velcro, it's too small. If it's so big that you're overshooting the Velcro or towards the end of the Velcro, then it's too big. So you need probably a bariatric, a pediatric, and a normal adult size cuff at your clinic or in the home health care setting, or make sure your hospital and skilled nursing facility has that. The arm should be at the level of the heart. If it's lower, that will give you a higher reading. And the arm should be relaxed. Any contraction of the arm is going to really mess up your reading. So there's a chart, box 3.6. What page is that on? Okay, that's on page 60. Highly recommend you have that memorized for boards. Box 3.6 and table 3.6. Those are both important for you guys to see. But box 3.6 specifically on page 62 goes over the different blood pressure contraindications for exercise testing, exercise training, etc. Know that. For exercise training, it's just some basic guidelines. If systolic blood pressure is over 180 or diastolic is over 110, you need clearance from a physician, and they need to have hypertension medication added to the regimen before you begin exercise, or they need to be on hypertensive medication before exercise. If there's any secondary organ damage, like retinopathy, renal disease, I'll just read you the full list. So retinopathy, microaneurysms of the eyes, nephrosclerosis of the kidney, chronic renal failure, congestive heart failure, angina, myocardial ischemia, atherosclerosis, stroke, then they need their blood pressure to be controlled at exercise and rest by medication. So you don't want to see any very high blood pressure readings with those patients, either at rest or with exercise. And as a hard and fast rule is any systolic blood pressure over 250 or diastolic blood pressure over 115 equals termination of an exercise test. This is not at rest. If this person had these blood pressures at rest, you would not even start them on the exercise program. You'd get them to their doctor. But it's normal for blood pressure to go up during exercise, just not this much. If you see any reading at this level, stop exercise, contact the physician. Okay, now we're on to cerebrovascular disease. So what is a CVA? Well, it's a stroke. It can also be a TIA, a transient ischemic event. Transient ischemic attack. Sorry, a transient ischemic attack. If symptom resolution is less than 24 hours, it's a TIA. If it's more than 24 hours, it's a stroke. Now, this is really the same disease process as coronary artery disease and peripheral vascular disease. It's just occurring in the blood vessels, the arteries of your brain, the circle of Willis. So just be aware of be fast, loss of balance, blurry vision, facial asymmetry, arm or leg weakness, slurred speech. It's time to call the emergency room. So be aware of the stroke symptoms in the clinic. You will probably see them, and you'll be in a position to save a life or improve somebody's function. A former instructor of this class used to tell a story, and he mentioned, seeing a patient, and he was having a hard time understanding the patient. And the wife of the patient would just say, "Oh, he's just talking silly, Oh, I think I told this story wrong. Oh no, I'm going to start over. Okay. So the patient comes in because they had a fall. And so he's interviewing the patient, and he says, "When did you fall?" And he said, "I just fell right now. I fell yesterday. I fall all the time. I'm always falling. My legs just give out." And then, so that was concerning, full evaluation. Then all of a sudden he has a difficult time understanding him. And the wife says, "Oh, stop it, George," or whatever his name was, He just does this thing where he starts talking silly all of a sudden. And so fortunately, the PT recognized that those were both signs of stroke, a loss of balance and weakness in the legs and slurred speech, sent him over to the hospital, and was diagnosed with having TIAs. These were just transient occlusions in cerebral blood vessels that were causing TIAs. So be on the lookout for that. Now, the prevention of stroke is the same as the prevention of heart disease. Modify risk factors, reduce risk factors. These are all the risk factors are here. A couple we didn't mention earlier necessarily. I think we listed them under, other risk factors were alcohol, sleep apnea is a big one. But the rest of these are all the same as before. Also medical management, similar med management, aspirin, lipid-lowering medication like a statin, glycemic control, so control blood sugar, and antihypertensive medication. Just like with heart disease or coronary artery disease, this will reduce risk. That brings us to peripheral arterial disease, which is really the same disorder, just in a different location. Technically, it's called I forgot an O here, atherosclerotic occlusive disease, AOD, and it is ischemia, but instead of myocardium, it is skeletal muscle. And so this leads to pain, and it's called intermittent claudication. Claudication just means basically a difficulty walking, and in this case, it's due to decreased blood flow. There's a neurological version as well, but we're talking about arteries in this case, so we're talking about decreased oxygen supply. This is just like angina, if you remember, in that it is predictive. It's predictable. It happens at a specific exercise intensity. If it gets bad enough, it can lead to resting pain, which is not good. Just like an unstable angina, that's not what we want. That could eventually lead to skin tissue changes, hardening, hemosiderin staining. Hemosiderin staining is associated with venous insufficiency. This would be more like necrosis or toughening, thickening, decreased sensation, which can lead to necrosis, which can lead to a loss of limb. 60 to 80% of these individuals have coronary artery disease. So think about that. What are the implications? Let me see if there's another slide. Okay, no. So, and here's another factor. 50% of the people who have this don't know they have it. But if someone has peripheral arterial disease and they don't have coronary artery disease, you should almost treat them as if they do, because there's a good chance they do. Most likely they also have coronary artery disease. So precautions that you would use with coronary artery disease, you should use with this. You should be on the lookout for chest pain. You should be on the lookout for TIAs, all that other kind of stuff, because they're all related. Exercise and PAD. So what happens with PAD is that you're getting decreased perfusion of the muscles, which leads to lactic acid buildup, which equals pain or claudication. Aggravating easing factors are the exact same as angina. So increased activity makes it worse. Decreased activity makes it hurt less, just like angina. The good news is that exercise is efficacious. Exercise has been shown to reduce the ischemia. Typically, this is measured in activity level tolerance. So, they'll design a study where the control group does nothing, and then the exercise group goes on daily walks, and they measure the distance and their ability to walk. Could be, they could only walk 100 meters without pain, but now they can walk 500. And so exercise is efficacious and it is statistically significant in most studies that I've read, which is great news. So in summary, we got through it, you guys. I went kind of fast, but if you have questions, feel free to email me. Feel free to pull me aside and lecture. There'll be a quiz for you guys to take. And so, if you feel like the quiz questions were just out of left field, let me know. There will also be some case studies after this slide that I'll tell you about. So, just a quick summary. Coronary heart disease is the most common disease in the industrialized world. As the American lifestyle sort of gets exported to the world, more and more countries are falling under this umbrella. It is dependent upon the presence of risk factors, which is bad news, but it's also good news because it means we know how to reduce the risk by addressing those risk factors. Risk factor modification is the name of the game. Coronary artery disease, peripheral arterial disease, and cerebrovascular accidents are all dependent on the same risk factors. So this whole category of diseases can be addressed by us as PTs. We're certainly in a position to make diet recommendations, lifestyle recommendations, and most of all, build exercise plans. And so we have a big impact on heart disease prevalence, especially in cardiopulmonary rehab. Okay, so there are two case studies on page 69. I have the 4th edition. So maybe I'll try to take a photo of these and post them in case you guys don't have the 4th edition. But you don't need to do both. I want you to pick one of them. It's a couple paragraphs of text with some questions. I'll post a submission form on Canvas. I don't need it to be super lengthy. You're not going to get extra credit for lots and lots of words. Just try to come up with a clear and concise answer that's less than 500 words. Okay, so I think this is a good opportunity for you guys to look through the text in case you missed anything that you need to answer these questions, but also feel free to ask me things that you don't understand. So thank you for listening. Take care. Bye.